Yes, one. Okay. Good morning. Today we'll see about umbilical hernia. So this is a case of umbilical hernia. In pediatric age group, umbilical hernia is very much common, and in adult, paraumbilical hernia is very much common. So the basic difference between these two is the umbilical hernia. In this umbilical hernia, the swelling will arise from the umbilicus, and in adult, it will arises adjacent to the umbilical area, that is periumbilical region. That is in the lateral aspect or medial aspect or superior or inferior aspect of the umbilicus. So this is common in the case of male, common in adult patients. In pediatric patients, the swelling will occur from the umbilical region. So we should know the definition of hernia. It's a protrusion of a part or a structure through the tissue normally containing it. So there are many type of hernia. One is inguinal hernia, second one is femoral hernia, umbilical hernia, and other types of hernias. Umbilical hernia can occur in pediatric age group and as well as in adult age groups. In umbilical hernia, as I told you, it can be a congenital or acquired. Part of the intestine or fatty tissue bulges through the muscles, through the umbilicus, through the muscles in the region of umbilicus. This is a umbilical hernia. So some structures will come out and goes into the umbilical region. It's common in pediatric age group in case of congenital hernia, and in adults, it can occur as acquired type of hernia. So we'll see both the type of hernia now. So in this class, we are going to discuss about the introduction and definition, anatomy, causes and risk factors, how to take a history, how to examine an umbilical hernia, how to investigate, how to manage, and what are the complications. So this is the introduction. Before going into detail, we should know the anatomy. So in between these two rectus, there is a linea alba. This is the site for umbilical region. So this is the linea alba. Linea alba. So this one is a linea alba. So through which all the content will come out and goes in, right? So this is the case of pediatric umbilical hernia. There will be a patent median umbilical ligament through which the content will come out and it will go in. So in infant, it's due to incomplete closure of umbilical ligament, and it can occur in premature babies and those with low birth weight. And in adults, it can be due to obesity, multiple pregnancies, fluid in the abdominal cavity like ascites, previous abdominal surgeries will cause incisional hernia most of the time, but it can cause umbilical hernia sometimes. So chronic peritoneal dialysis. So these are the etiology for umbilical hernia. So how to ask a history? You should obtain history of swelling, predisposing factors, and complications related to complications and past surgical histories. In swelling, how it started, where it started, and how long this patient is having the swelling. Whether did you notice it by yourself or someone noticed? How did you notice? Like that, all the histories we should ask to the patient. And does it disappears on its own or it will require manual reduction? Is there any change in size, shape, and color? And we should ask about, do you have any previous similar case? Do you have similar episodes of this swelling? And do you have any other swellings elsewhere in the body to rule out other hernias and other diseases? Next, predisposing factor. Why we want to know about the predisposing factors? Because these predisposing factors are the things that will increase the symptoms. Suppose if a patient has a swelling, if if a patient coughs too much, or if a patient is having COPD, then the size of the swelling will increase. And if a patient is presenting with the pain, that will increase the intensity of the pain. So we should know the predisposing factors. Do you have chronic cough? Because that will increase the intra-abdominal pressure, and that will again aggravate the swelling size, and pain also, it will aggravate the pain. So chronic cough, we should ask the history about chronic cough. Chronic constipation, do you have a history of chronic constipation, whether a patient is passing stools daily, or he is having constipation, he is passing once in 2 days, 3 days? Do you lift heavy weights? Because it will also increases the intra-abdominal pressure. Multiparity, many pregnancies. So these are the things that will increases the intra-abdominal pressure. And can you stop this? Okay. Next, so we have to ask about the predisposing factors like chronic cough, constipation, and lifting of heavy weights, multiparity. So these are the things that will aggravate the symptoms like swelling and pain. So we have to ask about the history of all the things. Apart from this, we have to ask about the history of difficulty in maturation also. That will also increases the intra-abdominal pressure. Next comes complication. So in history itself, we have to rule about the causes and complications. So these predisposing factors, that will also sometimes be the causative agent for this hernia. If the hernia is present for a long duration, then patient will have complications like, so initially patient's swelling will be reducible. Later on, that will become irreducible. So this is the second stage. First stage is the reducible hernia. Second stage is the irreducible hernia. Third thing, it will go in for obstruction. Then next stage is the strangulation. Then there will be incarceration. So these are the complications of the hernia. If you take any hernia, it will go into these stages like reducible will become irreducible. So first stage is reducible, second thing is irreducible, third one is obstruction, then strangulation, then incarceration. So these are the complications. So in a case of history taking, you have to rule out the complications by asking some of the histories like, do you have this abdominal pain, do you have abdominal distension, do you have vomiting, do you have fever, whether you are passing urine normally or not, whether you are passing flatus and stools normally or not. Because this, if you ask these histories, you can know about the complications like reducibility or irreducibility. Reducible is uncomplicated hernia. From irreducibility to incarceration or the complicated hernia. So you can rule out these things with the help of your complication history. Then you have to ask about the other symptoms. So in history of present illness, you should ask about the swelling history, pain history, causes histories like smoking, in chronic cough, constipation, lifting heavy weights, difficulty in maturation. In complication, abdomen distension, vomiting, fever, obstipation, and constipation. So these are the histories you will ask to a patient with a hernia, whether it's a umbilical or inguinal hernia. Then comes past history. Past history you can divide into two things. One is the medical history and another is the surgical history. Medical history, you should ask about all the medical conditions like diabetes, hypertension, bronchial asthma, ischemic heart disease, and tuberculosis, any other blood transfusions. And in surgical history, you can divide again into two things. One is specific to the case, and other was one from is a generalized surgical history. So in a case of hernia, in case of umbilical hernia, you should ask about the history of any previous surgeries, whether they have done any surgeries in the abdomen previously, because that will cause umbilical hernia later in case of adult patient, not in the case of pediatric case. So this is the significance of asking surgical history. Okay. Then next comes personal history. In personal history, you should include about the diet, bowel and bladder habits, sleep and appetite, and addictions. Addictions about smoking, alcohol, tobacco, and betel nut chewing. Okay. Some patients will have familial conditions. So collagen disorders will cause hernia in the that will run along the family members. So you should ask about the family histories. Okay. Then treatment history. Treatment, whether patient had taken any treatment for the present complaint or not. Then drug history. Some patient will be aware of some drug allergies. So that also you can include in the history. So this is about the history taking. In history taking, you should um, ask about the his chief complaint, history of presenting illness, past history, personal history, treatment history, and drug history. If a patient comes to you, if a female patient comes to you with a hernia, then you should ask about the menstrual history also. Then examination. In a case of umbilical hernia, first of all, you should do general examination like all the other cases. So you should look for patient consciousness, orientation, and febrile or not. Then you should check the pulse rate, BP, temperature, respiratory rate. All the vital signs you should check. Then you should check the Pickle sign, pallor, icterus, cyanosis, lymphedema, clubbing, lymphedema, and generalized edema. Then you should examine the patient in uh, proper light with a good exposure, adequate exposure you should examine. So first of all, you should inspect the swelling. So in inspection, you should check for the site. So all yes, site, size, shape, surface, skin, scar, sinuses. You should check for all the yes. Then any dilated veins, any visible pulsation is there in the swelling or adjacent to the swelling. Any visible gastric peristalsis, any visible intestinal peristalsis, anything is there. Any other swelling is there apart from this umbilical hernia, umbilical swelling. And genitals, apart from these things, you should check for the genital. You should examine the genital. So these are the things you should inspect. Okay. Then palpation. In case of palpation, you should check for warmth and tenderness. Then you should confirm the inspectory findings of the swelling, like all the yes, like site, size, shape, surface, skin, scar, sinuses. So you should check everything in detail. Wait. So everything you should confirm by your palpatory method. Okay. Then consistency. You should check for the consistency, whether it's a solid or soft or firm in consistency. Right. Then comes plane of the swelling. Plane of the swelling is the plane of the swelling is nothing but from where the swelling arises. So it's arising from the skin, or it's arising from the subcutaneous tissue, it's arising from the muscle, or it's arising from the preperitoneum, or it's arising from the peritoneum, or it's from the retroperitoneum. Like that, you should divide everything, all the abdomen compartment, and you should check from where this swelling is arising. Okay. So plane of the swelling, you should check for the plane of the swelling. Most of the time it will be in the peritoneum. Okay. Intra abdominal content will come out through the opening, right? Then mobility, you should check for the mobility, pulsation. Suppose if you get a cystic swelling, you should check for transillumination fluctuation. Okay. So um, most of the time in hernia, you won't do fluctuation and transillumination. So these are the things given in the slide. Identify the hernia, look for the mass in the area of facial defect, define the border. And one more thing I forgot to tell is the extent. You should tell the extent of the swelling, the size of the facial defect, size. So you should check for the defect size. Generally, asymptomatic in the case of children's, and in case of complicated hernia, patient will have all the complications, symptoms. So strangulated hernias are differentiated from incarcerated hernia by the following things: pain out of proportion to examination findings, fever or toxic appearance, pain that persists after reduction of hernia. So these are the things will be present in a case of incarcerated hernia. So for a pediatric case or adult case, whoever comes to you with the umbilical or paraumbilical hernia, you should investigate the patient before doing some procedure. So basic investigation for all the patients who comes with this swelling in the umbilicus or some other region, you should do general investigations like blood investigation and urine, X-ray, chest X-ray, and ECG. In blood investigation, you will see complete blood count, uh, blood sugar, and to assess the renal function, you will do serum urea and creatinine, blood grouping and RH typing, bleeding time and clotting time. In chest, you will do chest X-ray and ECG. That is for anesthesia purpose. If you are doing some surgery, then the patient's cardiorespiratory status should be stable before doing some surgery. So these are the general investigations. And specific investigation for a hernia, you should do ultrasound abdomen. In a case of umbilical hernia, you can do ultrasound of the abdomen. You will see in ultrasound of the abdomen, you can see the defect size, what is the content, whether it's a bowel or a momentum, whether the bowel is viable or not, and whether there is any collection of fluid inside the sac. These things you can rule out, you can know in with the help of ultrasound. So this is a specific investigation for a umbilical hernia. Suppose if a patient comes to you with a complicated hernia, then in case of if ultrasound is inconclusive, then you can go for CT scan abdomen, right? Complete blood count, X-ray chest, ultrasound. Treatment. So for all the patients, we won't do surgery. Only this defect will close within 4 to 5 years, except for the symptomatic patients, like all the complicated cases like irreducibility, obstruction, strangulation, incarceration, and this we will do surgery. So in the case of if the defect is more than 2 centimeter, there is a more chance of developing complication. In such cases, only surgery is the treatment of choice. Any defect that that persists beyond 5 years of age should undergo surgical repair. Okay, this is for congenital hernia. Congenital hernia, that is a umbilical hernia. Okay, for para-umbilical hernia, we should not wait and watch. We should do surgery because the complications are more in case of adult patients rather than pediatric case. So when you should do surgery in case of adult, if the patient is obese, chronic of constipation, right? So most of the time, these will cause complications. So in case of adult patients, you should not wait and watch. So surgery. Surgery is the treatment of choice for umbilical hernia. In case of pediatric age, we will not keep a mesh. So that is known as umbilical herniorrhaphy. That is known as Mayer's repair. We will do double bursting of the muscle layer. So overlapping has been made, and with the continuous sutures, we will complete the procedure, right? So this is about the herniorrhaphy. So we'll do herniorrhaphy for a pediatric age group. So this is the case of hernioplasty. Hernioplasty, we will do it for a case of adult. Suppose, imagine this is the hernia content. This is the bowel. This is the bowel. This is the intestine is coming out through the defect, which is in the fascia. Okay, so we will reduce the content and we will close the defect. That is known as herniorrhaphy, and we will keep a mesh over the defect area. This is a mesh, that is proline mesh. There is a polypropylene mesh. There is a non-absorbable mesh we will keep over the facial plane. That will give strength to the muscle wall so that the intestine will not come out again. So This is how we will prevent future occurrence of hernia. So this is the umbilical herniaplasty. So this we can this is the procedure of choice for adult case. In pediatric age, we will do only herniorrhaphy without mesh, and with mesh is known as herniaplasty. We will do it for a adult patients. Sometimes, in a case of adult patients, the abdomen muscle will be very um, very much thick, and they will have excess fat. So we will combine the procedure, like we will remove the excess fat. This is known as paniculectomy or additional lipectomy. This is the procedure of choice for excess fat in the abdomen. Along with the umbilical hernia, they can do abdominoplasty. This is known as abdominoplasty. So skin, abdominal wall, weakened wall, and the intestine is coming out through the peritoneum. Okay. Oh, so this is the first stage. Initially, it will come out and it will go in. Later on, it will get obstructed. Then it will become strangulated. So complications of hernias are incarceration, strangulation, and sometimes if there is a bowel, it can perforate. So recurrence and hernia at the port site in case of laparoscopic hernia repair. Hematoma, seroma, and wound infection can occur postoperatively. Thank you. Okay.